Next, we will have Dr. Jithma Abeykoon from Mayo Clinic Rochester talk about another challenging case study. I hope he doesn't hide some clues from us. But the clue was the blood pressure, an atypical Erdheim-Chester disease case.
All right, thank you, everyone. So this will be similar to the previous case, presentation-wise, but I want to highlight very important clinical questions that I face all the time when caring for these patients. Maybe it's me, but let's see. So we have the experts here. I will ask anyone in this audience. You all are experts, so please feel free to chime in. So objectives, discuss key unanswered clinical questions in the ECD. That is the main objective. It's not that I'm going to give you some very unique case that you have never seen, probably not. So explore them through an interactive case and agree on practical takeaway clinical points. So this is a 51-year-old male referred for evaluation of possible Erdheim-Chester disease. So the background was actually resistant hypertension. So we will go through the background and then walk with you for the diagnosis. So initially in 2019, this patient had episodic generalized abdominal pain. So the episode happens about a week, generalized pain. It's not like left flank pain or anything like that. And this associated with low-grade fevers and night sweats. So important, when we talk about constitutional signs of malignancy, as you may see in diffuse large B-cell lymphoma, Burkitt lymphoma, you don't see that verbiage in indolent cancers, like follicular lymphoma, for example. So, but this patient had low-grade fevers, night sweats with these episodes, and then abdomen image was done, and it showed soft tissue ringed around bilateral kidneys, bilateral adrenal glands, liver, and spleen. We will go through another, we have the images in our future slides. And splenomegaly was mild, 16.1 centimeters. They did the retroperitoneal biopsy. They did the retroperitoneal biopsy, and it on 2019, it showed inflammatory fibroblastic tissue. IgG4 was stained, and it was negative. So then the management was, you put the patient on ibuprofen, not at Mayo Clinic, this was outside, and possible short course of steroids. Actually, patient got a little bit better, like ibuprofen here and there, steroids got better, episodes decreased. Now it is not lasting for, not occurring every month. Now it is like once a year per se. So 2019 to 2022, now the patient developed resistant hypertension. By definition, hypertension is resistant for a diuretic. 4 antihypertensives were commenced, and then cardiology workup was done, and overall, non-contributory, So in July 2022, the patient developed now, instead of a diffuse abdominal pain, now this patient has right to left flank pain. And recurrent fevers and night sweats now, much more frequent now occurring, and little bit of fatigue too with this. So repeat CT abdominal pelvis, persistent and mild progressive perirenal soft tissue rind, involvement of proximal ureters was seen, ongoing splenomegaly, bilateral adrenal enlargement was seen. Renal artery duplex ultrasound showed no renal artery stenosis. CT abdomen, no vascular pathology. TTE, transthoracic echocardiogram, unremarkable. Cardiac CTA, 48-hour Holter, laboratory parameters, mostly unremarkable. So these are the symptom review. Absent symptoms were, no vertigo, ataxia, polyuria, polydipsia. So you can see the negative signs, but the positive signs are intermittent nocturnal muscle cramps, like Charlie horses were seen, and then occurring every 6 months, predominantly in the thighs, and fevers, night sweats occurring during these pain episodes. Physical examination, almost unremarkable. after the managing of the blood pressure by 4 antihypertensives, mostly unremarkable, nothing I could appreciate. And social history is never smoker, cancer screening, up to date, normal PSA, and rest are completely non-contributory. So these are the radiology findings of this patient in 2022. You know, we have enlarged images in subsequent slides, but involvement is seen in vascular, pericardial, adrenal, peritoneal, perirenal, mild splenomegaly, and then bone activity was seen too, as you can see here. So this is the adrenal, peritoneal, and perirenal. You can see the adrenal involvement here. Adrenal involvement, and then you can see the perirenal involvement, and you can see this rind appearance from the imaging. And here is the small spot, similar to the previous presentation. We did not see very significant, like the H sign that of the radiology for associated with ECD, but we do see some sclerotic uptake here. And this is the pathology. We did the biopsy. Pathology slides were from Dr. Karen Reck. And so you can see this adrenal gland. You can see this adrenal gland here, and you can see the lymphohistiocytic infiltration and residual adrenal gland surrounded by this angry lymphohistiocytic infiltration. And these are the markers: HNE, CD163, cyclin D1, and factor 13A. So before we go to the diagnosis and management, I just want to ask from our panel, for these questions come to me all the time. So first thing, do you think, can ECD present with constitution signs of malignancy such as similar to, Burkitt lymphoma or diffuse large B-cell lymphoma? Or in your mind, ECD is still an indolent cancer?
I'm not sure it's A versus B, but I think the answer to that question is yes. I think many patients feel terrible. It may have been so long that they don't recognize it anymore, and it may have become secondary to some sort of acute organ dysfunction, and it's not everyone, but I would say it's fairly common.
Yeah, I would completely agree. And for me, this links it a bit with JAK2 mutated diseases, kind of constitutional symptoms.
Thank you. So this is actually, sorry.
Yeah, so agree too. I know the case, so I'm not going to comment too much, but I think the typical B symptoms are quite uncommon, but certainly constitutional symptoms are not uncommon.
Yeah, very rarely we have seen night sweats. I would even say in pulmonary LCH, we have seen some night sweats type symptoms. But yeah, general constitutional symptoms like fatigue, weight loss, we've seen it.
And in your mind, Erdheim-Chester disease, yesterday patient presentation, it was still classified as a slow-growing indolent malignancy. Is it indolent or is it, an aggressive cancer?
Go ahead, Ron.
ECD is okay. Indolent or, well, I think if I were to think of lymphoma, this is more like an low-grade lymphoma type trajectory or phenotype, for the most part,
Yeah, I think, or like MPN, we even see follicular lymphoma having a high disease burden. We have seen patients with follicular lymphoma having night sweats and constitutional symptoms. I think it's just how you think about it. If I treat lymphoma, I don't know what you think about from MPN aspect, but similar.
I think it's a complicated question because the overall trajectory is indolent, but you can have a life-threatening complication in days or weeks. So I don't.
Got it. Thank you. And then we all know there is an entity called atypical ECD, and from our experts, how frequent do you see atypical ECD without characteristic bone findings and so forth?
I think you have to look hard enough, at least. But there are few with more awareness, at least I am seeing more and more of those cases. That's why we juggle that question to call it adult xanthogranuloma or ECD. Just the awareness in XG-type biopsies in pathology and other communities rising. I don't know what others think.
So I can give you some data. It's on our poster. That was just a survey of the cases that are discussed at this advisory panel in the UK, and a very simple comparison in the frequency of bone involvement compared with the historical series, and it's only about 50% in our patients, and they've all had pets. So I think that reflects earlier diagnosis, that maybe the bones aren't involved at the point of referral.
And that actually reflects the next one. So Dr. Goyal said we need to look harder. Do you think a bone scan is more sensitive detecting the bone involvement than a PET scan? Or if so, do we have to do bone scan on patients who have negative PET scans?
I don't know how others practices, but I have cases where PET is normal, or there is like very little signal like you were showing in your scan, or you were, but the technetium scan, and actually those patients got diagnosed because the orthopedic surgeon did a technetium scan. I would typically just do a PET scan. And since then, I've accumulated a handful of such cases. I think a bone scan, I've not seen the other way around, where the bone scan is completely normal and the PET scan is normal, but I've not studied it systematically, nor am I aware of data. I know Eli has some experience.
Yeah, I'm not aware of data. I almost never order a bone scan anymore. I do an MR, and if that's negative, then I believe that to be negative. But I think it's important just to say that I always look at the images, look at the legs again 1 or 2 years later, because they can declare itself. It can declare itself later.
Thank you.
Would you do an MR just of the lower limbs?
Yes.
Yeah.
Yeah.
This is just another practical, maybe very simple question. How frequent do you see vital sign changes? You know, the blood pressure, the cardiac, just a normal, when in the clinic, when you come to the patient, you have the sheet, your vital signs, they're abnormal. How frequent do you see in patients with ECD?
In Alabama, it's very high. Blood pressure is mostly high for most of my patients. I don't think it has anything to do with ECD, but others can comment.
Yeah, I think uncontrolled hypertension, like this case, it's not common, although certainly I think there's maybe 5% of the patients may present like this, maybe in retrospect, because when they come to us, they're already controlled. They're already on 5 drugs, yeah.
And just to piggyback on this question for all our providers here, do you think that if a PET scan shows no bone involvement or a little bit, do we need, like if we don't have access to MRI of their whole body MRI or something like that, should we do because doing a bone scan is relatively easy for most other institutions, even internationally. So do you think as an expert panel, do you recommend doing a bone scan to see whether classic ECD appearance there?
So in our workflow, in our UAB program, we discuss this. So we have a pituitary clinic. So they'll often see patients with undiagnosed, like DI. So we discuss, I mean, they don't want to order PET scan on everybody. So bone scan seems it's easier for them to do a first screening test. I don't know what other institutions do.
Yeah, I kind of went over a little bit quickly on the PET scan. I was impressed at the intensity of the adrenal involvement.
Yeah.
I'm just trying to put together your blood pressure and your fevers with the adrenal gland. Is that intensity in the adrenal gland?
Yeah. Well,
as much as it looks there, which is more than I normally see with ECD? Or?
The adrenals here is pretty involved.
Mm-hmm.
Yeah.
It's a little unusual.
Yes, and I think Dr. Harosh has.
When you say bone scan, bone CT scans like with technetium-99 or it's...
Yes,
okay.
nuclear medicine bone scan.
Yeah, I think it's a good option if you don't have access to like PET scan.
All right, thank you.
But also MRI of the long bones if you want to, if you have a doubt or no uptake on the PET scan, it's also an option.
Thank you. Yeah, that's helpful. Last question, maybe on this, I have another checkpoint. So does adrenal testicle involvement, do you think that increase CNS involvement similar to lymphoma, neurodegenerative disease, maybe?
I know Jerome is here, he did the series on ECD-RDD overlap where testicular involvement was primarily RDD with MAP2K1. I don't know if we saw a signal of CNS involvement with that, but I know it's in lymphoma we worry a lot.
No degeneration with MAP2K1, like it's between 0 and 1 case out of a lot.
So I think more the mutation and where it happens, yeah.
Got it. Thank you. All right, so we will go through this quickly. So differential diagnosis should be entertained. This is the most leading differential diagnosis that we have because of the imaging, long-standing, slow progressive disease here since 2013, and inflammation that manifests as fevers, night sweats, and pain, resistant hypertension without renovascular disease, multisystemic involvement, pathology, and IgG4 negative signs. So, but in this context, the other diseases that we should be entertaining would be IgG4-related disease, but for this patient, IgG4-related disease is less in the differential diagnosis because of a negative stain. And then other things would be idiopathic retroperitoneal fibrosis, where the against diagnosis would be bilateral adrenal and splenic involvement is atypical for idiopathic retroperitoneal fibrosis, and episodic systemic inflammatory symptoms are atypical, and imaging suggests infiltrative disease rather than a focal fibrosis. Of course, lymphoma is in the differential diagnosis low indolent, but it doesn't appear to have like a extreme lymphoma appearance in the lymph nodes, and also no lymphadenopathy, and the labs looks unremarkable, no cytopenia, and biopsy showed no lymphoma involvement. Sarcoidosis is another this type of the diagnosis that could happen, which can cause FDGI with lesions. And against the diagnosis would be no pulmonary lymph node or skin involvement, no granuloma on the biopsy, and then overall fit is very low. So we did the NGS on the tissue, and the NGS showed MAP2K1 alteration, gain of function, VF was around 15%, and these are the VUSers. And then patient was started initially, patient was started on cobimetinib, and 2 weeks on, 1 week off, and then initiated in 2022. Duration was 3 years, and you can see a complete response. So you can see here the involvement in the adrenal, and almost a complete response, and patient is doing very well. So the checkpoint 2 for the question-wise is that do we have to treat the patients with targeted agents although they have a MAP kinase pathway? Is it a must? Do you think if the patient has a MAP kinase alteration and the patient needs treatment, any of our experts would consider a non-targeted agent? In anti-inflammatory or chemotherapy or any other agent? And if you do so, what type of situation would it be?
Well, I offer both treatments to every patient of mine, and certainly go over the, response rates and side effects and duration of therapy. And after that discussion, certainly I give my opinion also, for situations wherein you require a rapid response, more critical organ involvement, then I will give my opinion as to perhaps let's do the TKI. But there are certainly situations wherein it can go either way. Yeah, so my patients we have a shared decision. Yeah.
Anyone else?
I agree entirely. I don't think this is relevant to your patient, but sometimes preserving fertility in the short or medium term can be of interest to some patients. And if someone like this, steroids bought them time in the past, and they're interested in childbearing, then you may kick the can down the road with steroids to allow for fertility.
Very good point, yeah.
You know, one thing I want to note about your case that was a little, I mean, there were couple of unusual things, the adrenal uptake and how even the perirenal was not the hairy kidney, it was more like a round.
Yes.
I sometimes see that in Rosai Dorfman, and with the MAP2K1 VF was quite high as well. So I don't know if was there testicular, was there a concern this is RDD overlap here, or I'm just curious?
No, I think it is actually Dr. Gore's patient. And there wasn't an RDD ECD overlap, it was ECD.
Okay.
And the next question is, we actually discussed this pretty well. How long should we keep treating with targeted agents? I think Dr. Diamond yesterday mentioned sometimes you treat for 2 years and then consider a treatment holiday. I would like to hear from the experts. What is your practice? How do you?
That's a good question. Yeah. You? Yeah.
I don't know the answer to that question. I think
What do you do in practice?
in practice, if they're on, so we're skewed by patient access scheme, because if you stop, you cannot get it back. So I think it would be nice. I mean, potentially a trial could be done on this, and it would be. I can't get out of my head what the pediatricians do with LCH, which is a maintenance treatment. So you could imagine a scheduled stop of targeted treatment. It's great to get rid of the burden of disease, but there might be benefit in a maintenance that is either a lower dose of targeted or interferon or methotrexate or something like that. I guess if my patient was already on targeted drug, I would probably de-escalate the dose just to keep, to a maintenance level.
Yeah, I agree with what Matt has said, and I think Eli's approach, certainly, I offer that to patients who are in a very good partial or near complete remission. Obviously, we discuss that because most patients, I should say, will ask that question, can I stop? And you give the data, and certainly our experience too suggests or shows that most patients who stop therapy will have recurrence. The challenge is to identify that 20 or 30% who will not recur or will not recur for years, and that's still an open question. Yeah.
Dr. Diamond, if I may, you brought a good point that you will consider a non-targeted agent in, if they are expecting childbearing, pregnancy and so forth. If a patient was placed on MAP kinase pathway, anyone can please, and then the patient would like to be pregnant, after one year of being on treatment, 35-year-old female. What is your approach? How do you manage this? And PET scan showed almost complete response, but still maybe the disease. We all know the disease might come back if we stop. How do you manage such patients?
I mean, those are very, very challenging cases. I think that generally people have to stop the inhibitors for a year before you'd even safely attempt a pregnancy in the first place. So within a year, I think most people have relapsed if they're going to within 12 months. So you have some data how the person is after those 12 months. And then you can make the best informed decision.
And I know practice patterns might be different from all of in our centers. Would you recommend fertility preservation before starting any targeted agent? including MAP kinase. Yeah, anyone.
Me personally, everyone.
Everyone.
Yeah, we just like, I had a patient this week, she's young, we planned to start MEK inhibitor. We referred her to reproductive endocrinology.
So fertility preservation is, do you put the patient on contraceptives, like, to stop ovulation for a female, or do you, preserve? Or for a male, do you do sperm banking?
Yeah. There are many options. So, I'm sure you all have reproductive endocrinology program. They work closely with us. So they give them all the options. We are able to do cryopreservation or, ovarian suppression. So whatever the patient chooses. Now, sometimes, at least in lymphomas that I treat, it's very aggressive and you need to start treatment ASAP. So that's the time where if they cannot do the ovarian oocyte extraction and preservation, they may either offer them, now we can do the ovarian, you can extract part of it, and then, or just suppression through hormonal suppression. Yeah, I don't know what others, if there is any other different. I don't think we choose the path. It's really reproductive endocrinologists who help.
But every patient deserves to see their
If they are,
reproductive
even if they have a remote intention or their childbearing age, to have a consultation at least. That's our recommended, at least at our cancer center also recommends that.
And then, my fourth bullet point, even in the treatment or even in treatment holidays, how do you monitor these patients? Is there a standard? For an example, in lymphoma, we know the standard of follow-up. What is your standard of following these patients? When do we need to repeat a PET? Every 3 months, 6 months, or do we have to if we show a complete response on a targeted therapy?
I usually repeat the brain early, and then the PET probably in a few months, but then you kind of ask yourself, let's say there's a light reactivation of the PET and they feel fine. Are you going to retreat them? Maybe not. So, if they feel well, I may do a PET in 6 months and then push it out, because really, I have some patients who have light reactivation, and they're like, you know what, I feel fine, and you don't re-challenge them anyway. So it's a question of, how much the PET sort of reflects how they're going to feel versus not.
And sometimes you can individualize a little bit, based on if it's skin lesions predominantly, you can know clinical response right away. And if it's brain is again,
right, if the brain reactivates,
I would
I'll
really,
probably restart anyway.
Yeah. So it depends on the organ, but initially if it's very widespread, may do more frequent actually. But once you get a good response, then you can slow down. And the NCCN guidelines also, I think, outline some of that.
And Dr. Bo,
Can I ask a question?
Yeah.
sorry.
Yeah. In my experience, which is far less than many of you up in the front, usually with CNS disease, my patients have symptoms return before any MRI findings come back. So it seems like a good history in following symptoms when they're off treatment may be more effective than the MRI. But I don't know. Are you seeing MRI recurrence before they have any symptoms recurrence?
I mean, I don't stop that many people with cerebellar symptoms, so this is somewhat theoretical. I think you're right. They'll have speech and balance problems maybe in the interval before you do the MRI.
Okay.
All right, and the last question is, do you usually check for germline when you do next generation sequencing of the tumor?
I think it depends on the panel.
Platform.
No.
And just depends on the panel that you use. Some panels require they require a paired germline sample, which we used to. Sometimes we end up with these variants that we don't know what to do with. And then there is some clinical history of cancer. Of course, everybody has somebody in the family who has cancer. Then I've not seen a great benefit that has come out of it, at least in my practice so far. We do identify some variants here and there. Or you'll see a SNP with a VAF that's very high in a gene that is potentially pathogenic in germline. Then they go to medical genetics. So that's our workflow. But I don't test germline mutations necessarily without knowing. Yeah.
Yeah, so I got it. Yeah, I agree too. It depends on the platform you use. Some are built in, And the benefit of having the germline also built in is to subtract the results so the patient doesn't get worried. It's not 65 mutations, only one BRAF. The rest are subtracted out.
Right. Thank you. So these patients, we assess the response through PET-CT, complete response. And then patient actually, this is case resolution.
We are behind.
Patient reports pretty well, and complete response, and clinically he's doing very well at the moment, and no reported toxicities from the cobimetinib. So this is the discussion points. You can all read this. So non-classical presentation, red flags would be hypertension, and tissue genomics are very important. And steroids may fail despite inflammatory symptoms, and that is usually characteristic for ECD. It's a steroid not unresponsive or less responsive disease. And MEK inhibition can deliver deep, durable responses. And response assessment and data capture matters. And PET scan is the yardstick, and standardization and recurring challenges do occur with respect to access. Not every country may have PET scan and all those targeted therapies. So these are I think we answered a lot of questions. Any other questions from the audience?